Salam everyone, this is Mostafa Alyassin, a third year student, and today I'll be talking about general points and notes regarding angina treatment in addition to few other drugs. Now, what is the first choice for patients with classic angina? Beta blockers are considered the first choice for patients with classic angina. But why? Why it's considered the first choice? Now imagine there is a subintimal deposition of cholesterol in one of the branch of coronary artery, and the area supplied by this branch is ischemic. So if we give the patient a drug that causes coronary vasodilation, the blood will go to other healthy branches, not to the affected branch, and this will lead to more damage to the ischemic area. So this is not our aim. Not our aim is to increase the oxygen supply. We can't, because we can't give a drug that causes coronary vasodilation. So here we want to decrease the cardiac work to make equilibrium between the oxygen and the work amount, or the cardiac work. Since we can't increase the oxygen supply, because what I just mentioned, we can't give a vasodilator. And because of because of our aim, which is to decrease the cardiac work, we will give beta blocker. Now, moving to the next point. For patients suffering from presbyteral angina, in which there will be vasoconstriction in the artery, not a blockage. One of the theories says that this happens because the patient has more alpha receptors than beta receptors. Thus, we can't give beta blocker, since in this case, if we give beta blocker, we will have only alpha receptors, which will result in unopposited alpha effect and alpha domination. So we can't give beta blocker. We exclude beta blocker in presbyteral angina. We also can't use alpha blockers, since this will not solve the problem, because thromboxane A2 also is one of the causes of vasoconstriction in the case of presbyteral angina. In addition, acetylcholine here, in the case of presbyteral angina, is not able to cause vasodilation. And in a case of beta blocker contraindication, we can give the patient calcium channel blocker. But which calcium channel blocker? We usually give verapamil, since it has similar effect to beta blocker, since it decreases the demands by decreasing the contractility and the heart rate. Thus, it decreases the work, as I just mentioned. Now, going back to presbyteral angina, what do we give them? We give them calcium channel blocker. Okay. Now, moving to the next point, which is the drugs that I'm going to talk about here. These include Nicorandil. Nicorandil, we call it the potassium channel opener. It goes to the cardiac myocyte and opens the potassium channel. So potassium moves out. This will result in hyperpolarization. Thus the muscles or the muscle cells will be relaxed. Another mechanism is that Nicorandil also releases nitric oxide, and it will increase the cyclic GMP and causes relaxation of the myocardium. So two mechanisms of action: the opening of potassium channels, potassium going out, hyperpolarization and relaxing of the muscle cell, increasing in nitric oxide, since it increases the cyclic GMP, and this will lead to muscle relaxation. Now, we mentioned in the organic nitrates video that we should not give we should not give or combine nitrates with sildenafil, since both increase cyclic GMP. Again here, Nicorandil, we can't give sildenafil with the Nicorandil, since it also increases the cyclic GMP, and this will lead to vasodilation, more vasodilation, and it may result in hypotension. The other drug I'll be talking about is Ranolazine. The mechanism of action. To understand the mechanism of action, I want you to recall that the sarcoplasmic reticulum here stores calcium, And one of the things that let calcium moves out of the sarcoplasmic reticulum is sodium entrance. So what does ranolazine do? Ranolazine comes and closes the sodium channel so it can't get into the cell and can't accumulate, thus calcium can't move out of the sarcoplasmic reticulum. Now, don't forget to prescribe for your patient also aspirin, which is an anti-platelet drug. Now imagine your patient called you at night and told you that his or her chest pain is not being relieved by nitroglycerin sublingually. What does this mean? This means that the patient now is an acute coronary syndrome. If we make ECG, we will notice there is ST elevation, which we call ST elevation MI, STEMI, and this means the infarction takes the full thickness of the heart muscle. In addition, in the blood there will be increased troponin in the blood and on ECG ST elevation. Now, in this video, we will discuss the pharmacological treatment of such case in which the patient will present to the hospital lately. Now, if the patient presented late to the hospital, we will use a mnemonic called monatuscut to remember what is the pharmacological treatment. Now, M stands for morphine. We will give 5 mg morphine IV. Morphine is an analgesic. It decreases the venous return, thus it decreases the preload. Okay. Another point about morphine is that it causes vagal stimulation, which is an important point, and you will know why in a few seconds. Now, in the cases of inferior MI, we don't use morphine. Why? Since in this case, the left anterior descending branch will be blocked, and thus the apex of the heart, which is the inferior side, and the septum will be lost. Now, here we will lose also the bundle. So the septum here, the apex and the bundle will be lost. Thus, this will lead to bradycardia. And morphine causes vagal stimulation, which causes decreased heart rate. So bradycardia because of the situation and decreased heart rate because of vagal stimulation because of morphine is not useful in this case. We don't want this to happen. It's an adverse effect. So because of this, we will use meperidine in this case instead of morphine. So morphine decreases heart rate. In the case of inferior MI, we basically have bradycardia because the bundle is affected. So we don't use morphine, you use meperidine, which is also another analgesic. Now O stands for oxygen. In the case of hypoxia, when the oxygen saturation is below 90%. Now N stands for nitrates. Why do you use nitrates? Because it limits the infarcted site. We can also use beta blocker instead. Anticoagulants, we will use the low molecular weight heparin. T for thrombolytics. S for sedatives, we will use diazepam. And C and T are for complication treatment. I will not mention all the complications. I will mention only the arrhythmia. In the case of arrhythmia caused by acute MI, we will use lidocaine. And thank you for listening. Bye bye.